Hi everyone, this is Gulirana and I'm going to tell you how to approach a case of worsening lower back ache. Just a reminder that this video is only for educational purposes as a part of STARMED medical educational program for our NACOSCE students. Each NACOSCE station is 11 minutes long and there is about 2 minutes to switch between the station. Carefully read the scenario. You will be asked either for a history or a physical examination or both. In some situation, examiner might ask you some questions at the end as well. Those 2 minutes, they're really important. Pay careful attention to the name of the patient, age of the patient, the task that's been given to you, and the problem that the patient is coming with. For the backache, remember at the end of the encounter, you should know if the pain is acute or chronic, mechanical or non-mechanical, and you have ruled out all the red flags. Acute pain is less than 6 weeks, subacute is 6 to 12 weeks duration, and the chronic pain is more than 12 weeks duration. Also remember that patient who are more than 50 years old and younger than 20, they're more likely to have secondary causes or non-mechanical backache. Backache is either mechanical or non-mechanical. Mechanical backache is more common and it's mostly triggered by movement and improved by rest. Non-mechanical is less common and it remains unaffected by movement, positioning, and rest. Here are some of the causes of the mechanical backache. 70% of the cases, it is either lumbar spine strain from muscle or sprain from ligaments. Other causes include degenerative diseases from disc, facet joints or ligaments, disc herniation, spinal stenosis, spondylosis, compression fracture, quadricular syndrome, scoliosis, and spondylolisthesis. In non-mechanical backache, there is always a secondary cause, which could be neoplastic, such as from primary spinal malignancy, metastasis, or multiple myeloma. Infectious causes include osteomyelitis, tuberculosis, abscess. Metabolic causes include osteoporosis, Paget disease, and osteomalacia. Ankylosing spondylitis and psoriatic arthritis may lead to reactive low back pain. And last but not least is the referred pain, coming either from a perforated ulcer, abdominal aortic aneurysm, renal colic, pancreatitis, and shingles. Now that you know the difference between the acute and chronic back pain, mechanical and non-mechanical back pain, we're going to discuss some of the red flags which are very important to rule out while you're taking history for the low back pain. And these include features of Cauda-Equina syndrome, including sudden loss of bowel and bladder control and settle anesthesia, severe worsening pain, especially nocturnal and or while laying down, significant trauma, weight loss, history of cancer, fever, use of steroids or IV drug use, patient with first episode of back pain while they are over 50 years old, and widespread neurological sign. So I put these three red flag more in a random manner and the way that I remember them. However, some people, they like to have a mnemonic, and I do have a mnemonic for you guys in my next slide. So here is the mnemonic. It's a tuna fish, which covers all the red flags that we have discussed in the previous slide. Trauma, unexplained weight loss, neurological signs and symptoms, age more than 50, fever, IV drug use, steroids, and history of cancer. Back pain is a very common presenting complaint with many different causes, as you have seen in the previous slide. So good history taking is very important so you're able to narrow down your diagnosis. Before we move on to history, once you're in the room, you need to introduce yourself. You need to confirm the name and age of the patient. You need to explain your task, ask for consent, and then proceed. Always start with an open-ended question like, what brings you in today? May I know more about your pain? And then you move on to close-ended question to get the information that you need. There are many different mnemonics that you could use. The one I used here is Socrates. Ask about the location of the back pain. Pain over the spine indicates spinal pathology, which could be infection, fracture, arthritis. Paraspinal pain could be due to a strain or sprain, and more lateral pain could be due to a hip pathology or renal colic. Clarify how and when the back pain started. Ask about the specific characteristic of the back pain. Back pain that is present at rest and wakes the patient up from sleep is typically associated with inflammatory arthritis like rheumatoid, ankylosing spondylitis, as well as malignancy. Pain that is described burning in nature is neuropathic and could be due to nerve root compression. Tearing back pain, typically associated with aortic dissection. Sharp back pain is not very specific and can happen in many different causes. Ask if the back pain moves anywhere else. Pain moving to buttocks or leg indicates nerve compression. Pain moving to groin may indicate renal colic, and abdominal pain could indicate either pancreatitis or peptic ulcer disease. Associated symptoms such as the red flags that we have already discussed, do not miss them. Eye symptoms in case you are suspecting reactive or inflammatory arthritis, urinary symptoms in patients who have pyelonephritis or renal colic, abdominal pain, nausea, vomiting may suggest pancreatitis. You need to know for how long patient they have been experiencing this pain, because it helps you to differentiate whether the pain is acute or chronic, and that will affect your management as well. What makes the pain worse and what makes it better? Typically, a mechanical back pain gets worse with the movement and improves with the rest. However, a secondary pain might not show the same characteristic, so it helps you to differentiate between the two. Severity on a scale of 1 to 10 is also important, and always show the empathy when the patient tells you that the pain is really bad or the pain is worse. You have to confirm with the patient how it is affecting their life, their physical activity, their social activities, any time off from work, any sport available at home. And this is a moment when you can always show patient empathy, that you understand that they've been going through a lot. Past medical history is very important, especially of any kind of malignancy, immunosuppression, any recent infection, inflammatory bowel disease like ulcerative colitis and Crohn's disease. You can ask patient about any spinal surgeries or social history like IV drug use, alcohol intake, smoking, medication, anything they've been using for back pain, or particularly immunosuppressive, corticosteroids, and the PPI use. Allergies to either medication or IV contrast, family history of inflammatory arthritis, any malignancy, cardiovascular disease, and then knowing patient occupation and hobbies, it helps as well, because it would help you to plan the management. Maybe the patient needs time off from work. There are certain physical activity that they might need to avoid for a limited period of time. Once you're done with the history taking, you can summarize the finding to your patient and tell them that you're going to move on to the physical examination. Ask examiner for vitals. Fever might indicate infection. A low blood pressure can indicate ruptured AAA, sepsis, or pancreatitis. Start inspection from front, back, and side. Look for any abnormality in posture, symmetry. Look for rash, deformity. Examine gait of the patient. You can always ask patient to walk on their toes and heels to check the motor function of L5 and S1. You can also ask patient to squat and rise to look for knee extension, which is for the nerve root L3, L4. You need to check the range of movement when the patient is doing forward flexion. Comment if the patient does or does not have scoliosis. Once you're done with the inspection, you move on to palpation, and you always need to tell patient that now you're going to feel their back, and if they have any pain or discomfort, they need to let you know. Check for the spinal or paraspinal muscle tenderness, and always percuss the costophrenic angle to check for the renal colic. This is the time when you can perform the Schober test if you are suspecting inflammatory arthritis. Once you've done all those tests, then you can ask the patient to either lie down or sit down to do the further examination, which typically is a neurological examination. For neurological examination of the low back pain, you are looking for the nerve root L3, 4, 5, and S1 mainly, and you need to look for their sensory in motor part as well as for the refluxes. Most of the motor part we have done while the patient was standing, but when the patient is lying down or sitting, you can check for the sensory examination and the refluxes. For L3, L4, you need to check the medial foot. For L4, 5, you need to check the dorsal foot. And for L5 and S1, you need to check the sensory part on the lateral foot. Once you're done with the sensation, check the refluxes, which includes patellar reflux for L3, L4, and the Achilles tendon reflux for the L5, S1. Tell examiner that you need to look for the settled anesthesia for S3, 4, 5, rectal tone, a full hip examination, and eye examination for the uveitis. Once you're done with the general examination, move on to the special test. One of these tests that I mentioned before is the Schauber's test for the inflammatory arthritis. It's best done when the patient is standing. You need to mark at L4, which is at the level of dimple of Venus. Mark 10 centimeter above and 5 centimeter below. Ask the patient to bend forward and measure the distance again. Less than 5 centimeter change indicates a positive test. I have added a YouTube link for you to watch and how this test is done. The rest of the tests, they are done when the patient is laying down. And the most important test of them is SLR and the cross SLR for sciatica or disc herniation. For SLR, keep one hand on the foot, raise the leg while keeping the other hand on the knee to keep the hip extended. If patient experiences pain at less than 70 degrees, then the test is positive. Once the patient has the pain, lower the foot to about 10 degrees and dorsiflex to reproduce the pain. It's a more sensitive test. For the cross SLR, you repeat same procedure with the opposite leg, and if the pain is experienced in the non-raised leg, then the test is positive. This is more specific test for the sciatica or disc herniation. Again, I have added a YouTube link for you to watch as well. Another test, which is the Faber test, is also done when the patient is laying supine, and it is for SIJ pathology or intra-articular hip pathology. When the patient is supine, you need to flux, abduct, and externally rotate the hip and place the foot just above the patella of the contralateral leg. You simultaneously press on knee and anterior spheric spine of the contralateral leg. If patient experiences low back pain, it indicates sacroiliac joint pathology. Anterior groin pain indicates intra-articular hip pathology. Now the last test is femoral nerve stress test to indicate L4 radiculopathy. It is done when the patient is prone. You passively flex the knee and extend the hip. If patient experiences pain on the interior thigh, it indicates a femoral nerve stretch or L2, 3, 4 nerve root injury. And again, I have added a link for you to watch as well. Once you're done with the history and physical examination, we're going to move on to the management, which depends on the presence of red flags as well as the chronicity of the condition. If patient has any features of caudate venous syndrome, the patient needs to be referred to emergency right away. If patient has any other red flags like worsening pain or nocturnal pain, significant trauma, weight loss, fever, history of cancer, steroid or intravenous drug use, they need to be referred within 24 to 48 hours. Patients who are over 50 years old and have first episode of pain and patient with wide neurological sign, they also need a referral, but they could wait for a couple of weeks. So any patient with red flags need a referral to ER or for surgical evaluation or relevant specialists. If there are no red flags, look at the chronicity. If the patient presents with acute or subacute pain, you need to educate the patient, because most of the back pain, about 70% it's going to resolve in 2 weeks, and about 90% is going to resolve in 6 weeks. So you always need to tell them that this could be self-limiting. There are some self-care strategies that you could use, such as alternate cold and heat therapy. They need to continue with physical activity as tolerated, and you always need to encourage patients to return to their work as soon as possible. You could consider analgesia like acetaminophen is first line, NSAID is second line. You could use a short course of muscle relaxant. Opioid use is rare for acute pain and is only reserved for severe or worsening pain. Remember that any patient that you see presents with acute pain, you need to reassess them in 1 to 6 weeks for development of any red flags, worsening pain, or inability to return to normal function. And if that's the case, you always need to consider imaging and referral to a relevant specialist. For patients with chronic pain, there are different analgesic options, including the one that you use for acute pain, such as low dose tricyclic antidepressant, short-term cyclobenzaprine for flare-ups, opioids for severe pain, epidural steroids, prolotherapy, face joint injection, and some of them, of course, might require referral to a multidisciplinary chronic pain program, community-based active rehabilitation program, and community-based self-management or cognitive behavioral therapy program. Patient could consider additional treatment option like progressive muscle relaxation, acupuncture, as well as massage therapy, aquatherapy, and yoga. Imaging is needed whenever red flags are present or if there is no improvement in pain after 6 weeks. Thank you so much for listening to this presentation, and I wish you good luck for your exam.